Hello everyone and welcome. Our webinar today is Moving Data Securely in an Era of Value-Based Care, how the direct protocol facilitates care coordination and patient engagement. We have a great lineup today in the presentation. We're going to be recording this webinar for future use and future reference. I'm just going to start out by introducing our hosts and our panelists today. And I'm going to quickly read through a brief excerpts of their bio. Bear with us as we join this and make some introductions here. We have some great panelists here and with fantastic backgrounds. I definitely want to make sure that we go through it and have a little bit of detail behind each of their bios. Lee Barrett is the Executive Director of EHNAC, Electronic Healthcare Network Accreditation Commission. Mr. Barrett's got 10 years of leading healthcare professional service organizations, as well as 20 years in senior management roles in payer organizations. He speaks nationally on a variety of healthcare industry topics and is involved in a number of industry coalitions promoting the use and implementation of health IT, including both administrative and clinical transactions, as well as the development and proliferation of EHR systems and meaningful use across the National Health Information Network and HIEs. Corey Mertz is a challenge Grant Director at the Office of the National Coordinator for Health Information Technology's State Health Information Exchange Program. Prior to joining ONC, he was Policy Associate at the National Conference of State Legislatures and served as a leading staffer at the Health Information Technology Champions Project, a public-private partnership that worked to increase state legislative leadership on health information technology. Holds a bachelor's degree from Iowa State University, where he focused on economics and political science. Andy Heron, Director, Network IP at Cerner, is responsible for aligning market needs with current capabilities for the Cerner network, a foundational component of a system which facilitates the coordination of care, incentives, and commerce across consumers, providers, and payers. Mr. Heron oversees intellectual property strategy and business development for the healthcare community interoperability, with a current focus on Cerner's use of the Direct Project standards. Mr. Heron is a founding board member of Direct Trust. Scott Ray is Vice President of Government Educational Relations and Senior PKI Architect at DigiCert. Mr. Ray is a thought leader and expert in public key infrastructure design, implementation, and operation. He's a founding member of the Direct Trust Board, currently serves as co-chair of the organization's Certificate Policies and Practices Working Group. A contributor to the establishment and operation of trust frameworks in multiple industries, Mr. Ray has spent significant effort helping to design the Direct Trust framework and has contributed to several other related initiatives, including the Direct Trusted Agent Accreditation Program. Ron Moser is Consultant Senior Site Reviewer for EHNAC. Mr. Moser has 30 years of professional IT experience, is a Certified Information Systems Auditor, and is certified in Risk and Information Systems Control. He provides leadership in the development of new accreditation programs, coordinates various advisory committees, and performs audits for all EHNAC programs. Mr. Moser is also the Managing Director of Moser House Consulting, which provides guidance to organizations that are committed to improving their operations through the implementation of effective risk-based IT controls. And finally, Dr. Holly Miller, Chief Medical Officer of MedAllies, serving as a physician liaison for all implementation projects and supporting the design of a change management program that ensures optimal utilization of health IT tools within implementations of certified EHR systems to improve patient quality and outcomes, supports PCMH transformation, and enhances care coordination. She's a frequent presenter on health IT and personal health record issues and served on the U.S. HIMSS board from 2008 to 2012, most recently as the role of Vice Chair. And with that, I'm going to turn it over to our host, Lee Barrett, again, Executive Director of EHNAC, who will walk us through the first few slides here. Again, welcome everyone, and I hope you enjoy the webinar.
Thank you, Dave, and hello everybody, and welcome again to the webinar. So as Dave has gone through introductions for the panelists, and we have an excellent panel today. We're going to be walking through a number of different aspects here having to do with secure data movement. So I'm going to be taking the opportunity to kind of set the stage for the webinar. So I'll be going through some introductory slides, then turning it over to Corey Mertz, who will be discussing ONC's role in the promulgation of the direct protocol and really enablement of secure data exchange, certainly at the federal level and what they are doing. Andy Heron is going to be talking about some of the experiences that Cerner has had in their role, both as a beta organization and really as they've seen a lot of direct promulgated and working with the industry. Scott as well will be talking about DigiCert's experience and some of the experiences that they've certainly had from case studies and what they're seeing in the industry and how it's, again, promulgating. Ron Moser will be talking about the direct and secure data exchange from a couple of different perspectives, and certainly from that of EHNAC as a senior site auditor and some of the experiences that he's had so that people can hopefully look to gain from his experience and knowledge. And then Dr. Holly Miller will be talking about the perspectives on transitions of care, and certainly from a patient-centered medical neighborhood, and a very, very interesting perspective that she'll also be bringing to the panel. Next slide. So let me talk through some of the objectives for the webinar that we're hoping for all of you to achieve. First of all, we're going to be talking about some of the progress that we've made over this past year in relation to the partnership that EHNAC formed with Direct Trust in relation to promulgating the direct protocol and accreditation program in the industry. We'll also be talking about some of the examples that are in the industry about interoperability and how it's really helping to drive the coordination and the whole aspect of patient engagement as well. And you're going to see several of the webinar panelists talking about that. And then we're going to be talking as well about some of the best practices and examples of how to facilitate not only security but interoperability and really trust amongst all the various direct exchange participants and stakeholders. Next slide. So further, we'll be talking through some additional examples of the value proposition as well as competitive advantages that organizations are seeing as a result of going through the accreditation. And we'll be outlining, how your organizations should be looking to prepare what you need to do. Ron Moser will be talking about some of the experiences that he has as a senior site auditor, as well as Scott and Andy talking about their experiences as organizations having gone through accreditation as well. Next slide, Dave. Some of the challenges as well, we'll be talking about, the role of direct protocol for secure messaging. We'll talk about authentication and the trust anchor bundle distribution system and how that's working and the benefits of it. How to manage risk and manage overall risk mitigation for your organizations, because there's a significant focus regarding privacy, security, confidentiality in all of this, and taking into account a lot, not only HIPAA, but high-tech, omnibus rule, and a number of other federal mandates that have been included in relation to the criteria that are used. As you can see, certainly the aspects of confidentiality as well, as we're looking to secure messages with all these various exchange models that are in play today. Next slide, Dave. So we're going to be talking about, as well, information flow, not only from the standpoint of PHI, protected health information, and how that flows, but also as a patient, wherever and whenever basically it's needed, across and between organizational vendors and other types of geographic boundaries. And you can see all the various connect points and all the various stakeholders really that are part of the connections and the need for exchange and securing the exchange of both clinical as well as administrative data. Next slide. We're also focused really on trying to make this as workable as possible from a contractual standpoint and between the connections. And so if we can get to the point of minimizing the number of contracts that are actually necessary and leveraging the direct and the direct bundle in relation to how and where all of this is authenticated, then we get to the point of really the cost is able to be reduced. We're able to reduce the number of contracts that are out there, and increasing the overall value to all of the participants and stakeholders is key. If we have to have separate contracts, it becomes very limiting, and we now have to have really an exponential number of contracts with all the various stakeholders. So it becomes very limiting as far as how we can look to scale in the industry. Next slide. So really it comes down to really the three major components that we're focused on here: the security and trust framework for the industry, the EHNAC direct trust relationship and the accreditation program that we've implemented, and the trust anchor bundle distribution in relation to all the organizations that are going through that accreditation are now part of that trust anchor bundle distribution. And now we start to see some of the costs reduced in relation to the numbers of contracts that are needed because the authentication has in fact taken place. We've started to establish that trust anchor, not only distribution, but also trust throughout all of the stakeholders that we're trying to create here. So with that, next slide. I'm going to turn this over to Corey Mertz at ONC to talk about the Governance Cooperative Agreement Program and some of the initiatives that ONC has been doing over not only this past year, but what they're looking to do in the future here. Corey.
Great. Thank you, Lee. Next slide, please. Great. Well, as Lee mentioned, I'm going to talk about the Exemplar HIE Governance Program. We launched it in March of 2013, and it was really an opportunity for ONC to work with existing organizations out in the health information exchange space that are trying to bring various parties together and provide some guardrails and rules of the road for the best kind of policy and security decisions that need to be made to ensure exchanges being done in a secure and appropriate manner. So we put this opportunity out to really partner with existing governance organizations out in this field so we could learn from them and also help the whole community learn from their experiences and kind of hopefully drive some good learnings and participation in these organizations. So we made 2 awards. One was to directtrust.org and the other was to the New York eHealth Collaborative. So I'm going to run through and talk a little bit about the experiences with those 2 organizations. So, next slide. So with Direct Trust, we were really excited to work with them on their trust framework for directed exchange. Laid out a number of key areas to work with them on in the first year of this grant award. And I think you're going to be hearing in more detail about a lot of these things, but really focused on kind of bringing the accreditation program up and running and kind of driving participation in it and making sure the various policies that Direct Trust had in place were aligned with various federal kind of ONC recommendations of what we thought were the right set of policies and procedures for directed exchange. So the first year went really great. Next slide. And I think we had some great experiences. So this past March, we renewed that grant for a second year. We're really excited to continue our work with Direct Trust in this kind of option year of the Exemplar HIE Governance Program. Looking forward to working in these kind of 4 key areas, really to kind of continue to advance the ball on directed exchange. And again, make sure the policies and procedures are in place so that people are going to be able to seamlessly exchange between HIS and between EHRs. That's really such a key part of this, and it's one of those key factors that we've built into the Meaningful Use Program around the transitions of care requirement for Stage 2, which some of the other presenters are going to be talking about in more detail, so I won't go into too much there, but we see this as a nice complement to the activities there, and we're very excited about the work moving forward over this coming year. Also, trying to work with some of the federal agencies that are interested in getting into and utilizing the direct standard. and a few other areas. Really that last one is about making sure all providers are able to participate in directed exchange, thinking about some of the maybe rural and underserved providers and making sure they aren't facing any kind of unique barriers to participating in the exchange ecosystem we're trying to promote here. So next slide. So with the New York eHealth Collaborative, they got the award on behalf of the EHR-HIE Interoperability Work Group. For those who are not familiar, that's a partnership of a number of states, HIE vendors, and EHR vendors. And they did some really interesting work through this grant of testing provider directory standards. So they brought together 4 pilot sites across the country with 14 pilot participants participating in those. It ranged from states to kind of HIEs to EHR and HIE vendors. They really worked to test the HPD plus directory standards and a few others. It was interesting to see kind of the different spread of what point in time and which version of HPD or other directory standards vendors had implemented. So it was kind of one of the interesting learnings that people were at various different points with that. And I think one of the key things coming out of it was we heard the strong desire and had heard prior to this award the strong interest in the community of driving towards a single provider directory standard. So next slide. So some great lessons learned. This grant program wrapped up in March of 2014. All their work had really been completed, and they have a final report that we're going to be releasing in hopefully the coming weeks and have it up on the ONC website. These are some of the kind of key lessons. Again, I think one of the most important things we heard from these pilots and from the community was that folks are very interested in getting towards a single directory standard. They see it as particularly useful for directed exchange, but a lot of the other things implementers and HIEs and others in the healthcare space are trying to do right now. I think there's a strong opinion amongst many that a single directory standard will help drive a lot of things that are trying to happen in the healthcare space today. And I think one of the exciting outcomes of this work also is that ONC is now partnering with IHE USA to work with them on updating the HPD standard to kind of drive towards that community requested single profile moving forward. So we're working closely with IHE on that, and I encourage folks who are interested in learning more about that. They can either contact me directly, and I can point you to the right people at IHE, or go to the IHE website, and you should be able to get the information on that. So just in summation, we are really excited about the work Direct Trust is doing and the work that the EHR-HIE Interoperability Work Group did this past year with that grant. Again, we really see the Exemplar HIE Governance Program as a chance to partner with organizations out there, making things happen in the HIE governance space, and we're really looking forward to continuing to work with Direct Trust over this coming year. So with that, Lee, I'll turn it back over to you.
Thanks, Corey. A terrific overview on a lot of the really excellent work that ONC is doing and the partnerships that we have. And ONC has been really promulgating over not only this past year, but for the past several years, and really interesting on the path forward here. So with that, we'll turn to Andy Herring, who's going to be talking about some of the experiences that they have from the Cerner perspective and some of the value proposition and some of the competitive differentiation that Andy and Cerner and he's seeing in the industry as well in his role, not only at Direct Trust, but in several other leadership positions that he's in. So Andy, turn it over to you.
Thanks, Lee, and thanks everybody for the opportunity just to kind of give you a view from the field, if you will. I'm gonna start off by doing that. I'll take you through a couple or a handful of things that at least I'll raise up as examples of what we're seeing and interesting things that are happening around use of Direct. One of my fellow panelists, Dr. Miller, later will cover a couple of these from a clinical perspective and offer you some deeper insight into that. But just to get started, I'm not going to go deep on the MU2 transition of care and you download and transmit objectives. I think most everybody is aware of those, but my report back to you is this: is that the number of endpoints are growing. I think we're up to 250,000, 300,000 within our direct trust community. I know Cerner, we've seen an extreme growth here as of late as hospitals and eligible providers start to attest to those objectives. I think we're up to about 130,000 addresses at this point. And we also, obviously, as a part of our solution set, have the capability for patients to leverage directed exchange to get information flowing to the places that need it. So the network is growing as we speak. We also we have some clients here in Kansas City that are participating in a closed-loop referrals. I wouldn't necessarily call it a pilot, but just a concerted effort. We have Truman Medical Center, who is a 400-bed acute care hospital, has about 12,000 acute admissions a year. Sam Rogers, who is a federally qualified health center, as well as 25 other organizations who basically got together to say, we need to get together and collaborate amongst our community for these safety net clinics in Kansas City, Missouri that all serve low-income, uninsured, or maybe even underinsured patients in our community, because the care coordination is not occurring the way we would like it to. They had several concerns. One, and this was in their words, and no offense to one another, they basically felt as though once they provided care to a particular individual, they called it the black hole as to the next step in the process. They just didn't have any insight as to where that individual stood in getting scheduled for the appropriate handoff and care that was recommended by that particular provider. They also were spending about 45 minutes per referral on things like phone calls and paperwork and those sorts of things that really were taxing the individuals that were trying to make this happen for the folks in this community. So what Cerner offered was to these organizations to help with this collaborative effort is a direct-enabled solution that's focused on the closed-loop referral workflow. And essentially, a few anecdotal points is that the black hole no longer is there, as there is a view into the steps and the process and the procedures as to where that individual needs to go next and the processes on the other side. They also took about 30 minutes off of each one of those referrals, which saves them the estimated roughly $2.77 a referral, again, based on the paper and the phone calls, postage, things of that nature. That, you know, when you're doing 30,000 referrals a year, that's real dollars that start to add up, as well as the underlying goal was to ensure that these folks were getting the appropriate care and the appropriate handoffs that were needed so that their care was administered not only appropriately but timely to help them live better, healthier lives. So the last one I'll throw out there to you is one of my colleagues on the Cerner behavioral health side has participated with in a pilot up in New York, the Software and Technology Vendors Association pilot, where essentially they are dealing with behavioral health information. And as you all know, ultra-sensitive data is contained in these clinical documents. And once you get past the patient consent to share that type of information as they are perhaps referred to a specialist, once you get past that part, there's a certain amount of process and procedure in today's approach that is back and forth of, do you understand that you are about to receive ultra-sensitive tag data? Yes, I do. Okay, here's the data, and now you must deal with it appropriately. Essentially what that pilot has come up with, through the use of direct, through a secure channel, they essentially take care of all those steps in one shot and one communication after the patient has given consent. Again, it's in pilot. It presents its own specific challenges when you're talking about the honoring of those ultra-sensitive tag data points once you get them into the EHRs. But point being, direct is being used once again to safely and efficiently get information from one place to another as care is coordinated. Next slide, please. So my last slide, and what I'll wrap it up with, is just to give you an idea of, from a HIS perspective, what accreditation has meant to us. Cerner Corporation was the first to pursue and achieve the DTAP accreditation. And the first point I'll make to you is this: is that we only have one shot at this. Providers are counting on this. They want to be confident in this because they recognize and realize that there is healthcare information flowing out over the open internet. So it is our role and our responsibility as a HIS to ensure and be stewards that while that data is in our control, that we're treating it appropriately and getting it to the right place through not only the technologies but the policies, the best practices around policies surrounding directed exchange. And I say it only takes once. One anecdotal point I'll make to you is that one of our clients was looking at our offering of direct as well as another competitive offering of direct that was not participating in the direct trust and DTAP accredited community. And the story that was relayed to me from the field is that during the demonstration, this competitive HIS demonstrated how a direct message ended up in a regular Gmail account. Unencrypted, PHI information, obviously it was demo, but needless to say, the very next day our client signed a contract to go with Cerner for directed exchange, not only because we are participating in this community, but also because we were accredited, and third party shows that we are leveraging those best practices, and it gives them the confidence that we're doing the right things. The second point I'll make to you is around the direct trust bundle participation. Accreditation provides us, or seeking accreditation to date has provided HIS like us the opportunity to participate in kind of a scalable, rapid growing network. And as I mentioned to you before, we are rapidly growing. The number of endpoints is becoming many. And what may not be seen is by participation in this community, and Lee somewhat hinted at this earlier in his slide, we don't have to do HIS-to-HIS agreements because by participating in that community through accreditation, there is a federation agreement that we all sign that essentially helps shifts and mitigate those risks appropriately, the same as what individual HIS-to-HIS agreements would do. The real benefit to us as a HIS, for example, is we're averaging around 30 minutes or less. I think even the last few were 8 minutes or less, to where we're notified of new HISs that join that community to the time when our users have the ability to exchange directed messages with them. We wouldn't even get through the first phone call with the lawyers for each side to do that in the same time frame. And while I love my legal counsel, I really do, I would rather not spend that much time with them. Lastly, accreditation and what the requirements of that accreditation program represent. It's really a complement to anybody's risk management strategy. For any of you who are familiar with the requirements, you'll know that they cover a variety of aspects, from technical to policy to legal to what are you going to do if situations for disaster recovery. It is a comprehensive view that helps you slot and think about all the different things that are important in our best practices for us who are providing HIS services in the industry. So with that, Lee, I'm going to end and turn it back over to you. Thank you.
Thank you, Andy. That was an excellent overview of really some very good case studies and examples of how direct has been implemented and deployed, as well as talking about the value proposals that you've seen from a Cerner perspective,
and the whole aspect around stakeholder trust, the provider as well as other stakeholders. So Andy, thanks very much. So next we're going to turn to Scott Ray, who's going to be talking from DigiCert's perspective, similarly about some of the value proposition as well as some of the competitive differentiators and the various stakeholders and roles that DigiCert and Scott have seen in the industry over not only this past year and certainly as they're seeing going forward. Scott, let me turn it over to you.
Thanks, Lee. I appreciate that. Dave, if we could move to the next slide, please. So I thought that I would start and talk about some of the participants in the trust framework. We have a protocol which details some of the technical attributes for exchanging messages, and but if you want to have end-to-end security, you need more than just the technology. You need the operators of the technology to be following policies that are consistent and also that tie responsibilities, relationships all together so that you have trust from one endpoint to another endpoint and consistent actions and responsibility for the private health information that's passing between two endpoints. And so the Direct Trust Network, or the Direct Trust Federation, however you want to call it, seeks to establish the community of participants who are operating in a consistent way. But there are a number of roles of different entities that are participating within that community. As you can appreciate, it takes an awful lot of heavy lifting from both sides to ensure that you have probably the most precious cargo that you can carry, which is someone's private health information, and to responsibly hand that from one party to another, and to do that securely across an open network like the internet. Now, it is possible to do this if you have the right framework in place. In order to establish that framework, if you pick the opening bar, if you're entering the community too high, folks won't be able to participate and you won't actually get critical mass necessary to establish the network that you need that actually brings the value in having the community. And so, as folks can appreciate, you can't swallow the proverbial elephant all at once, and it usually works to break it down into bite-sized pieces. And in an attempt to do that within Direct Trust, we established 3 different entities, and I'm going to talk a little bit about those, and DigiCert represents 2 of those entities certified, and I'll finish speaking about our experiences going through the DTAP program with EHNAC. So the entity who's kind of at the top of the tree is the HIS, the Health Information Service Provider. And they have the responsibility for assigning those addresses and accounts where providers are actually going to exchange messages, and to manage their access to that, to do appropriate binding of the identities behind those account holders. You can have a secure channel, but if you don't know who you're talking to at the other end, your secure channel won't really mean much. And so identity proofing is a really important aspect of our community, and knowing who we're dealing with and who's actually accepting responsibilities, sending and receiving the messages that we're talking about. And so the HIS have a responsibility there, making sure that the accounts that are set up are configured correctly and that that identity processing is occurring, and that they're creating. We utilize a technology called public key technology, public key infrastructure, PKI, is the base of the technology that carries these messages backwards and forth. And if you implement PKI correctly, it's probably the strongest, most secure system that we have today for sending messages across a public network like the internet. So the HIS, the Health Information Service Providers, they operate the infrastructure. They make it possible to allow a provider who is their customer to exchange messages not only within the HIS own boundary, in the case that Andy was talking about for Cerner, not only amongst all of Cerner's customers, but they also provide a gateway so that all of Cerner's customers can also speak to anybody else who's also in the network, in the federation. They offer a range of services to be able to make sure not only that their customers are who they're claiming to be, but who they're communicating with. They can actually have trust and assurance in who they're communicating with through the program, through the DTAC. This is facilitated through the DTAC program. If we can move on to the next slide, please. To assist them in their role of providing the messaging infrastructure and the account infrastructure, there are two other entities that we define within Direct Trust. There's a certification authority, a CA, or a registration authority, an RA. And they do specialized processes within the community. They are subordinate, if you like, to a HISP, in that a HISP may employ an RA to provide a certain portion of their trust, but the HISP will take the ultimate responsibility. Same with the CA. May employ a CA to provide a certain portion of the trust processing that needs to occur. But again, the HISP is the one who takes ultimate responsibilities. And there's a little diagram we'll get to in a slide or two that explains the relationship between HISP, CA, and RA. But I just want to spell out here that basically your CA, they are the ones who are creating the credentials. And within the Direct Trust community, again, we're using PKI that uses cryptographic keys and digital certificates. So the certification authority's role is to create credentials underneath a trusted, it's called a trust anchor, and these are the things that get placed into the trust bundle that was mentioned earlier in the presentation. So the CA operates and manages the trust anchors, and beneath that trust anchor they issue certificates to end entities, and end entities could be organizations or they could actually be individuals who actually have accounts with the HISPs. The RA, the registration authority, their role is to reliably proof the identity of responsible parties, whether that is someone who owns an account or whether it is someone who has been designated at an organizational level as the representative for that organization if the organization operates an account at an organization level. So RAs are primarily concerned with identity proofing of individuals and potential organizations as well, making sure that organizations are real and that individuals are who they claim to be. And we leverage within the trust framework standards that are utilized across multiple other trust frameworks that are used elsewhere. We're not recreating the wheel anywhere. So the policies that RAs follows are fairly common. And the policies that CAs follow, again, CAs operate in a number of trust communities, not just within Direct Trust. And the policies that the CAs within Direct Trust operate under, again, are very similar to other frameworks. Where Direct Trust is unique is the implementation of the Health Information Service Provider, the HISP. If we can move to the next slide, please. So the Health Information Service Provider is something that's unique to Direct Trust. This is the entity that is taking on that role for ensuring that identity proofing is going on, either by doing that itself or employing an RA to do that on its behalf, if that RA operates in the community already. Or, and the HISP is also ensuring that the credentials that are then utilized as part of the trust in establishing the accounts that they manage are also managed in an appropriate way. They can do that themselves, or they can outsource that to a third party, a CA, who does, again, that portion. And as I mentioned earlier, both CAs and RAs are fairly standard entities that are certified in other communities, and we leverage those within Direct Trust as well. So there are a number of ways that a Health Information Service Provider, the HISP, has for implementing the services that it wants to provide. It can provide all the services itself, or it may only provide the services and rely on an external CA, external RA to do a portion of that work for, or piecemeal, it could rely on a CA and do the RA itself, or vice versa. It could rely upon an external RA and do the CA portion itself. So a HISP has options in the way in which it wants to implement, and this actually provides for some efficiencies in the community. And I want to talk to some efficiencies if we want to go to the slide, please. So when we, in the community, we have the Direct Agent Accreditation Program, DTAP, that EHNAC operates for Direct Trust. And the three entities, the HIS, the CAs, and the RAs, are what can be accredited. Over to the right-hand side of the slide there, you will see that each entity has a set of policies that it needs to follow, and it will be audited against those policies. It will publish a statement about its practices and how those practices meet the policies that it is claiming to follow. And then there's an accreditation process for each entity, and where EHNAC audits the entity according to their policies and observes their practices to make sure that they're consistent. And in doing so, we can ensure that we have implementation end-to-end of policies and practices that are consistent amongst all the entities. And as you can see, there's a hierarchical nature to the entities that we have. RAs who are doing identity proofing will typically do that on behalf of either directly with the HIS or for a CA, and then the CAs who are managing the credentials that are issued as a result of the identity proofing that has occurred will do so under the direction of a HISP, and then the HISP who are setting up the accounts will then utilize those credentials that have been reliably identity proofed to individuals of responsibility to actually provide the services. And this is how the trust is built in the community. Now, as I indicated earlier, HIS can perform all those roles themselves, or they could potentially outsource some of those to another party. And we saw within the trust community there is an awful lot of policy and technology that needs to be proven in an audit if you're going to be audited for all three. And so to help in a bootstrap process to make it more efficient for HIS, we thought we could break it down into three areas, and we did find that that certainly made it easier for members who were coming to be accredited under DTAP to focus on each of these areas in succession and be able to become accredited. It also made it possible for an entity like DigiCert, the company that I work for, who operates as both an RA and a CA, to provide services to HIS, so that a HIS who wanted to function in providing services and perhaps did not have as much experience and technical expertise as is needed to operate a PKI. They didn't need to acquire that before they could become accredited. It should become fairly easy for them to outsource that to an entity like a DigiCert who is capable of providing those services. If we could move to the next slide, please. So I just want to touch at the end here on some of the benefits of utilizing an already accredited CA and RA. I've alluded to some of these and what I said previously. We wanted to reduce the time and the cost that a HIS might have who wanted to join the Federation, and allow them just to focus on the messaging aspect. They wouldn't need to worry about the other aspects if they were utilizing somebody who was already accredited. Some of the benefits of doing this I've listed out here on the page. It provides a much faster implementation time for HIS. We have received a lot of feedback in this regard. DigiCert provides services to a number of HISPs who have come to us, and we've actually had feedback from HIS customers directly who have indicated anecdotally that they are grateful that their HISP chose to outsource that portion of their services, because it meant that they are actually able to receive services much faster than was originally planned. It provides lower setup costs for HIS. You can appreciate that RA and CA services that are being leveraged for a number of HIS. There are economies of scale that come into play when that occurs, and you can provide services for RA and CA services at a much lower cost when you have shared infrastructure by a number of HIS, rather than having to set that up and manage it all yourself. It also allows HIS to focus primarily on their main objective, which is the messaging portion. I already mentioned economies of scales, but there are efficiencies that can be gained if a CA and RA are operating in an efficient manner, it means that all the HIS that they service gain benefits, and so the whole community benefits much faster as services that are being provided that are found to be more efficient are implemented. They get implemented across the number of HIS automatically all at once, rather than HIS by HIS having to implement any efficiencies that were determined. From a scalability perspective, it makes it very easy for a HIS, again, who may have not been in the business of providing services based on PKI. Scaling a PKI can be a challenge, and all of those worries can be handed off to your third-party partner if you're talking about an experienced partner like DigiCert. I should point out that DigiCert is a commercial certification authority, and we provide these services in a number of trust communities. We have been a provider of services in healthcare, but mostly those services were dealt with internet security and securing websites that health providers might be running, etc. But we also provide identity management for individuals in a number of communities, and we are able to bring that experience to Direct Trust and to the HIS that we service within Direct Trust, so that enables them to ramp to internet scale. We're talking about billions of transactions, being able to facilitate billions of transactions on a daily basis, to be able to provide that capability to our partners who are HIS, who are looking at providing services. So a HIS who's implementing can know that the services that they rely upon from a DigiCert can scale to the infinite, basically, and we have experience doing so. One of the other communities, trust communities, that DigiCert does happen to operate in is the federal PKI community. So we have credentials that are certified and trusted by federal agencies, and the federal agencies have their own certification program for making that happen. We are able to make those same credentials available to our partners who are HIS within Direct Trust. So somebody who is certified under DTAP as a HIS and is using DigiCert as a partner is able to also have their credentials be trusted within other trust communities, specifically ones that they want to interoperate, like CMS and IHS and CDC, etc., federal agencies that are looking to utilize Direct to move messages from their community within federal space to the external community, public community. So we have had a number of partners who are HIS who have utilized DigiCert specifically for that advantage. They haven't had to worry about the PKI aspect because they know that they have a partner who has a proven track record and is certified in other trust communities as well. B, they know that they can obtain federally accepted direct messages as they become important to interoperate with partners in the federal space. And it also has really shortened their lead time and what they need to focus on in becoming accredited. And so there is a space of time that's granted for someone who needs to go through the DTAP program that's operated by EHNAC, and it can be a number of months. Folks who have partnered with DigiCert have significantly reduced the amount of time that they've had to spend in the accreditation program because they only had to focus on about 1/3 of the metrics that they would need to otherwise, because they had a partner who is a CA and an RA who was already cross-certified.
Hello, Scott. Did we lose you?
I guess we lost Scott. Scott, if you're there, thank you very much for really going through defining the roles, responsibilities between the stakeholders. That was very helpful, I think, to everybody in understanding how all those stakeholders fit within the trust community, and also talking about the value proposal and the benefits to each of the players. So thanks very much, Scott. So next we're going to hear from Ron Moser, who's going to take us through the DTAP accreditation program. He's also going to be talking about some of the specific items that you can do if you're interested in going through accreditation and you're asking yourself, well, what do we need to do to in fact prepare? What are the things we need to be aware of? What are the key success items that are important? Ron's going to take you through some of that, and from his experience as a senior auditor for EHNAC. So Ron, let me turn it over to you.
Thank you, Lee. And let me just start by saying it's been a lot of fun developing this program with people with the expertise such as Andy Heron and Scott Ray. It's amazing the amount of information they've brought to the table and the amount of work they've done in putting together the whole Direct Trust program, as well as the other individuals with Direct Trust, and in partnering with EHNAC. It's been a really neat experience. I think there's an excellent program here for all the reasons that have been presented. In my presentation here, I'm going to cover the following areas. Basically, I want to cover the basics of what an organization needs to do in order to become accredited. So this will be very high level, but it should provide a good overall view of what the process looks like. I'm going to cover the accreditation steps, the basic steps that an organization has to go through to become accredited, preparing the self-assessment, some of the main areas within the self-assessment report, critical success factors, programs and sections, how the scoring works, and then some other notes that provide some other key points that need to be taken into consideration. So regarding the accreditation steps, one of the first things an organization needs to do is to identify, and this is pretty much from an EHNAC auditor perspective, there are other things in aligning with Direct Project and understanding their processes. It's good to go to directproject.org and learn as much as you can about becoming a participant in Direct Trust. And by the way, one of the other things I wanted to comment on is along the line of what Scott was saying, and that is it's good to do what you're good at doing well and finding partners that excel in other areas, such as aligning with an existing CA and RA rather than having to build that yourself. So I think there's a lot of value in that, kind of like the same thing companies have to analyze today with respect to building their own data center versus outsourcing to a highly competitive market of data centers out there, and finding what really provides your needs without having to go to all the efforts of putting in place what perhaps someone else already has put together in a way that will provide you the most value for your money. But so identifying your sites, it's kind of a segue into this. One of the things that's very important is that you identify each site that either your organization has or where you use third parties for processing the services you provide, and also anything having to do with customer support services or any place where there's access to highly sensitive data, such as PHI, or the way in which keys are handled, such as the stores of the digital certificates for your customers. So we are very focused as site reviewers on where the data flows, and it's important that you understand what sites are used, whether your own or whether they're outsourced, because we have a responsibility to physically review sites that are integral to handling the sensitive information. Then applying for accreditation, you need to know, again, what programs you're going to apply for, whether you're being a HIST, and whether or not you're outsourcing your CA or RA. And again, you can do 1, 2, or 3 of these yourself, and you need to apply for whatever programs you're doing. Any of them that are outsourced must be EHNAC accredited. Preparing the self-assessments is a matter of taking the package. Once you've applied for accreditation with EHNAC and you've become a candidate, they will send you a package that includes all of the criteria and all of the forms you need to complete to demonstrate how you meet each of the criteria. And you also provide examples. You provide evidence that shows examples of how you meet the various criteria, and we have a way that all of that is linked together, and then it's submitted to EHNAC. You will then host site visits that the site reviewer comes on site to review. Again, your corporate site, any data centers or processing locations. And then after the site visits are conducted and the site reviewer has gone over where you are and has reviewed any follow-up items you might need to still provide, you will provide those. And once the report is finalized, the organization going after accreditation is able to, and always is required to review that report to see if there's any disagreement. And then it's submitted to the EHNAC Commission for ballot, and they provide an electronic ballot out to the commissioners to vote on the accreditation that the site reviewer recommended. So that's basically a real quick step through of going through accreditation. Next slide, please. So preparing the self-assessment is really the biggest part of the project, because you're talking about 100+ criteria that need to be met. There are 6 different sections, I believe, covering the first 5 sections really cover all of the aspects of a lot of the core criteria EHNAC has in all of their programs, which includes HIPAA compliance, demonstrating that you have your HIPAA house in order in terms of policies and procedures and training and business associate agreements. We also have various areas that we look at in terms of your technical performance and how you measure your system uptime versus what you market in, or what you have in terms of your SLAs with customers. We want to make sure that you are truly delivering what you've promised to your customers. You need to have, along the line of HIPAA, really it starts with having, and a good organization will say not only along the line of HIPAA, but along the line of your whole organization, you should have a risk assessment in place where you've really evaluated your entire organization and the services you provide, and you should identify the threats against your organization, basically the likelihood of those threats occurring and the impact such a threat would have on your organization, and show how you've addressed those threats. And we are, since you're processing healthcare information, we have a special focus on how you've identified the risks to PHI and what measures you've put in place to make sure those risks are appropriately mitigated. And so the risk assessment is a key foundational part of putting together your whole program. And again, with respect to HIPAA, it's having the appropriate documentation and such in place with your HIPAA compliance office. You should have a designated privacy and security official, and you should have your PHI flows documented, and again, demonstrate the business associate agreements that you have in place. Breach notification policies are important, and then in terms of the overall packaging of your self-assessment, we provide a lot of information, and it's very critical that an organization reads the instructions we provide and that you put your package together based on those instructions, and we provide instructions on how to hyperlink your evidence to your, basically to your comments in terms of how you meet the various criteria. So next slide. Some of the critical success factors in achieving accreditation, it's really important with respect to the DTAP programs that you perform all the tests. As a HISP, you have responsibility for performing the various NIST tests, including the transport testing and certificate discovery testing, and just making sure that all of the various criteria that outline all of these things you must have in place. It's important that you do them all and that you demonstrate clearly that you've performed them and that you meet them. With respect to Direct Trust, they provide a certificate policy, and that policy is updated from time to time. You should go to directtrust.org and get their latest policy, and then make sure that you're either adopting that specific policy or that you create a policy that conforms to theirs. And then based on that, you need to have your own certification practice statement in place that shows how you meet all the various aspects of the certificate policy, what your implementation is of that for your CA and for your RA. And then the basically for the CA it's called a certificate practices statement, and for the registration authority it's called a registration practices statement. Those must be in place, and criteria specifically address various portions of those statements. So the key documentation that's provided for the final section within the criteria is really centered around the certificate practice statement, the registration practices statement, or the HISP practices statement, which I'll touch on in a future slide. But if you're, depending on which accreditations you're going after, whether HISP, certificate authority, registration authority, or any combination thereof, these practices statements provide the bulk of the evidence showing how you meet those requirements. And we have criteria within the EHNAC programs that then points to those statements. Next slide. So the programs that we have are called DTAP HISP, DTAP CA, and DTAP RA. And as I mentioned before, each of the programs, the first 5 sections are very similar, if not identical. So if you're applying for multiple programs, you can actually cross-reference your cross-reference the evidence that you're providing in the other program, so you don't have to do it 3 different times, as long as it is exactly the same for each of them. And then section 6 is the section that's unique for each program. Next slide. Scoring for these programs, for each criteria you're given a score of 0 if you fail it, 0.5 if it's partially met, or 1 if it's fully met. And then we take the score across all of the criteria, and you have to achieve a minimum of 85% to achieve full accreditation. But in addition to that, there are many criteria that are designated mandatory. So irrespective of your score, you must fully meet each of the mandatory criteria. And Section 6 of each of these programs, within Section 6, most of the criteria are mandatory. So to be a HISP, a CA, or an RA and achieve full accreditation, you need to fully meet almost every criteria in Section 6 of each of these programs. Next slide. And then just some final notes in going through accreditation. Again, an organization can apply to be accredited for any or all of these programs. If multiple programs are pursued, common responses to common criteria may be cross-referenced, so you don't have to provide that in each program. If no PHI is handled by the organization, for example, if you're a CA and or an RA, then the PHI-related criteria should be addressed based on PII controls. If you don't ever process any protected healthcare information, then you should treat the criteria that reference PHI with respect to the personally identifiable information you provide. But HISPs, we always regard as handling PHI, even if you make the argument that you can never really come in contact with it. The fact that you're a HISP and you're providing the types of services you're providing, there are both responsibilities in terms of how you're handling healthcare information, and deep within your programs there's de-encryption and re-encryption taking place. So we consider the PHI to be fully relevant to HISPs. And if a HISP does not provide its own CA or RA services, again, the CAs or RAs that are used must be EHNAC accredited. And I'll pass it back to Lee. Thank you very much.
Ron, thank you very much. That was an excellent overview of the whole DTAP process and gaining your perspective on what people need to be thinking about if they're going to go through the application process. So thanks very much. So now we're going to turn to Dr. Holly Miller, who will be talking about the perspective on transitions of care and the whole patient-centered medical neighborhood, which is a very interesting concept. So we'll turn it over to you, Holly.
Hi, could you go back a slide, please, on the title? Thank you. So I actually wear 2 hats. I'm the Chief Medical Officer for MedAllies. We offer a triple accredited national HISP and full HISP services. We do excel in all of our accredited areas, as well as having a MedAllies mail product for non-certified or paper-based providers or healthcare facilities that want to receive messages and be able to send messages via direct. I actually requested to present last today as I wanted to refocus the discussion this afternoon about direct on how this technology is fundamental for our ability to care for our patients as they transition across care environments. I'm also, in that context, the medical director of the Taconic IPA, which is a greater than 5,000 plus physician organization. And as an internist, the focus that I want to make is going to be clearly clinical, starting with an examination of the current state of care transitions. Next, please. So fundamentally, we have very significant communication deficits as our patients are transitioning across care environments. And you can see the data on the screen. But essentially what this means is if I'm seeing a patient for the first time after that patient is discharged from the hospital, I end up asking the patient why she or he was admitted to the hospital, what medications they were discharged on, and what the follow-up needs to be. Because most of the time, or a large percentage of the time, unless I'm working in an integrated delivery network, may very well not have any information about the hospitalization the first time I'm seeing the patient after they've been discharged. This also means that as patients are referred from primary care physicians to specialists and they show up in the specialist's office, the specialist will need to ask the patient, why are you here? Because they may not have information about the patient from the primary care physician. And then when the patient's seen the specialist, had their medications changed, received additional treatments and diagnoses, the primary care physician may not have information from the specialist, so they again are asking the patient, what did the specialist say and how did they change your treatment regimen? Next, please. There's many studies that demonstrates, next please, that essentially about 20% of patients that are discharged from hospital experience a serious adverse event. Next please. These are most frequently medication errors, and they are due to what we've been talking about, this ineffective communication, where information is not flowing as the patient requires when they see a different provider. And so clearly the part of the process that is the most vulnerable are these transitions of care, and this is when the adverse events occur. Next, please. There's been tremendous focus on how are we going to improve these transitions of care, and there were many incentives that came out of the Affordable Care Act. Next, please. The most notable is really the Meaningful Use Program. And now, for providers and organizations that began attesting, at least for Medicare, in 2011, next, they're going to attest to stage 2 this year. Next, please. Stage 2, next, has greatly increased and enhanced the requirements pertaining to transition of care. It's now a core requirement that more than 10% of patients that are transitioning or being referred have an electronic transmission from the sending provider using certified electronic health record technology to the recipient. And clearly, the identified technology is the direct protocols. Next, please. But in addition to meaningful use, there are other incentives that came out of the Affordable Care Act towards transitions of care. There are 2 new CPT codes for transitional care management. Many value-based purchasing programs were begun. In 2011, there was the Community-Based Care Transition Program. 2012, we saw the start of many, many ACOs. And 2013, the Comprehensive Primary Care Initiative began out of the CMS incentives programs. The Comprehensive Primary Care Program was a novel program which required multiple payers to contribute to improvements in primary care. And next, please. As the medical director of the Taconic IPA, I'm also the leading, the director of the regional learning faculty for the Comprehensive Primary Care Program in the New York region. We have 74 participating practices. Next, please. So the Comprehensive Primary Care Program fundamentally has a 3-part aim of better care, improved health, and reduced costs. Next, please. The middle area had the areas of focus of the program, which include access and continuity, planned care for chronic conditions and preventative care, risk stratified care management, patient and caregiver engagement, and very importantly, coordination of care. Next. The program has 9 milestones, and many of the milestones involve transition of care. Next, please. But milestone 6 fundamentally, next, please. Milestone 6 fundamentally focuses on transition of care across the medical neighborhood. Next. Where the practices are required to develop systematic coordination of care across their medical neighborhood. Next. So within the medical neighborhood, the primary care team has already learned in patient-centered medical homes to really collaborate with each other and to have all members of the team working at the top of their license. Next. But in this program and others, as we move to the patient-centered medical neighborhood, the primary care team, and in fact all provider organizations, need to start collaborating and coordinating care with others beyond their own practice or their own hospital. Next, please. So we've been discussing DIRECT as the linchpin technology for provider connectivity. Next. Next. In the New York region, with the CPC project, we've also been creating agreements between the providers about how and when they're going to use DIRECT as their patients transition across care environments. So if connectivity is direct, then the relationships and agreements is rolling out DIRECT as a catalyst to forge better relationships and care transitions for patients between clinical trading partners throughout that community. Next. These care coordination agreements include aspects of specific accountability for different aspects of care. So these agreements might include setting expectations about how and when the information is going to flow. For example, when a patient's discharged from hospital, the care agreement might include that the hospital discharge message needs to be sent to the primary care physician prior to or simultaneous with the patient leaving the facility, enabling the primary care patient-centered medical home team to have timely follow-up with the patient. This is particularly necessary for the highest risk patients, and these often are the patients that are most likely to bounce back to the hospital and be readmitted, and often because of an adverse event. The care coordination agreement might also include defining what the core data set would be for each transition circumstances. In the New York area, we've set the goal of using that meaningful use to defined data set at the outset in our agreements. It also has an expectation that the patient fully understands why they are transitioning. For example, if the patient is being referred to a specialist, that's been fully discussed with the patient and they agree and they want to go to the specialist. It also often defines who is going to manage the patient in an emergency. And finally, that the entire care coordination agreement would be reviewed in a time frame where the participating healthcare providers and organizations would review the agreement and see if any changes are required. Next, please. So currently, when we don't use direct technology and interoperability, the workflow around transitions of care, if we're trying to get the information to flow with the patient, is highly disruptive to the electronic health record workflows that the majority of hospitals and practices have adopted at this point. So the work around communication is all outside of the electronic health record, with letters, phone calls, faxes, picking up fax documents and scanning them into the EHR, etc. Tracking transitions of care requires manual data entry, and this is usually or frequently done either in the EHR if that's been built as a feature, or potentially practices and facilities are tracking this information on spreadsheets. So clinicians and staff want direct. They want to have a communication method that's in their electronic health record workflow. It facilitates this being easy. Next, please. And not only does direct function within the electronic health record, but actually as the data, next please, has the meaningful use stage 2 data often has been defined with standardized vocabulary data elements. Data such as medications, problems, and allergies can be pulled into one EHR from another. This eliminates transcription errors and facilitates medication reconciliation at the time of transition. Next. And next. So what we're looking to do is to transform these patient-centered medical homes into a patient-centered medical neighborhood using direct so that information flows across that neighborhood as needed wherever the patient needs to be cared for. And we're seeing this function successfully. And I will use a quote of one of our providers who said, his experience of direct, and I'm paraphrasing a little bit, but he fundamentally said that he saw this as the holy grail of medicine for transitions of care. And I'll end there. Thank you.
Ollie, that was excellent. That was really, I mean, talking about really as a model, it's a tremendous model for collaboration and, focused on quality of care and really how direct becomes a very significant technology enablement for really the exchange of data, both clinical as well as administrative, between the various stakeholders. So terrific example. Thank you very much. So with that, Dave, why don't I turn this over to you to facilitate questions that we might get from the audience as we go into the QA segment of our webinar.
Sure. Thank you, Lee. And thank you to those who have been live tweeting with us during the webinar as well. Lee, some questions have come in. We have one here. Can you provide a view from the field showing examples of the successes with or the key challenges of accredited HISPs exchanging healthcare information? I don't know if one of our panelists could jump in and answer that question.
Yeah, Dave, this is Andy from Cerner Corporation. I'll jump in and let others jump in as well. I think from a success side, I gave a few examples earlier where we're rapidly within the direct trust community seeing the number of endpoints growing, so the network is there. So I think that is definitely a positive. I think we have seen several of our clients attest to meaningful use. So as Dr. Miller just went through, there's certainly some expectations for using direct there, so we know those are being met. So I think those are positives. I think from a participation in the community as well as being accredited, I think that comes with tangible business positives and successes there, where it makes us more efficient to operate our HISP as well as and build out the network, as well as knowing that we're participating in a community that also is holding themselves to those same standards and best practices, so that our respective providers and people using direct have that confidence they need. Opportunities out there, as with any new standard that is being adopted by the industry, I think we're seeing a few variations in the interpretation of those standards. So I think we have some opportunities there to come together and address those. And one example is within the direct trust community, particularly those participating in the bundle. We have, as a part of entry into that bundle, a expectation that interoperability testing is performed with everybody else in that bundle. So we recognized pretty early that just the self-attestation and use of these standards maybe wasn't enough. We're seeing some variation there. So we got together and we started addressing and started working through some of the issues, because we want to be that de facto community that you can communicate with one another there. We have some work to do, and even perhaps I know we've discussed this, Lee, at a EHNAC direct trust level, that perhaps there's some things we can even add into our accreditation program to help address that particular aspect. So I think we have some opportunities there. I also think too that even us on the electronic health record side of the house, I think we all have some opportunities to further embed direct into the workflows of the clinicians and administrators and folks who are doing the phone calls and the paper shuffling and the faxes today. We always talk about how Apple didn't come out with the iPhone 5S the first shot. So I think we're kind of there as an industry now, and I think we all respectively have some opportunities to go even further embed this capability into some meaningful workflows so that folks can find value out of that.
I'd like to answer from a clinical standpoint, if I may.
Absolutely.
So taking silence as yes. I think, and Andy addressed some of this as well, but I think perfect is the enemy of good. So it's interesting at times when, as we bring clients live and physicians who previously had no information at all about the patient now have the Meaningful Use 2 data set, which includes the patient's problem list, the active problem list, the active medication list, the allergies, fundamentally life-saving information and information that will prevent adverse events, and immediately want more and more and more. So I think recognizing that this is a process, that EHR functionality will continue to greatly improve and enhance what's available as we move forward with the technology, but step one is to get that fundamental clinical life-saving information across that medical neighborhood. The other observation that we've seen at times is you've got one large organization in a community, and they come up and live with Direct, but because they don't have clinical trading partners that are also on the same timeline to go live with Direct, they are not having folks they can trade with. So that at times can be very frustrating to organizations as they are moving forward.
Thank you, Dr. Miller. We also have a few other questions coming in here. How will a PCP launch a direct transaction from their EHR, so a primary care physician?
This is Andy. Yeah, this is Andy from Cerner. You know, from our perspective, there's various ways. For example, in Cerner Millennium, we have the ability to launch direct communications from within clinical reporting. So the folks who traditionally are sending fax communications, for example, of charts and records from one place to another. So once again, you know, with emphasis back on kind of meeting those folks that have those use cases in the place where they're used to it is definitely key. One other place we have direct enabled, or example of a place we have direct enabled, is within our, what we call our message center. So think of it as don't think of it as any more than an inbox in the EHR itself. So it was a natural place to kind of allow directed exchange to occur. We're also connecting direct capabilities to what normally would have been report distribution, so some of those automated processes, and instead of sending out, once again, over fax, packaging those up as attachments and sending them out over direct. Those are just a few examples, and we have, you know, I mentioned the other example of Cerner Behavioral Health is releasing capabilities for folks in that space to initiate communications from within that particular workflow as well. So there'll be many more examples, but those are just a few of where we've started.
Great, thanks, Andy. We have another good one here from our audience. We've heard a lot about benefits of using Direct. Can the panel talk about the challenges of deploying and using Direct?
This is Andy from Cerner. I'll go ahead and go again. And if this was, if we could have a video conference, I'd lift up my shirt and show you some of the battle scars, if you will, some of the challenges out there. But you know, what we're really finding is that I think we have a nice foundation of expectations for what folks should do through our accreditation, and I think that's a great place to start. What we are specifically finding is that there's variability in the implementation of that for each particular instance that wants to leverage it. One example that we consistently run into is people getting the proper domain name service addresses or capability set up, so DNS settings. You know, for those of you familiar with use of the internet and addresses and email servers, you have to know where to go to deliver that mail, and those DNS settings help to understand that. But they vary by every implementation, assuming that there's a different address and a different DNS registry that needs to occur. So we're finding that, you know, all the right processes are in place up to that point, but actually implementing, we're finding some variation out there, and it prohibits, it from just working day one. We're working through those. We're seeing kind of a, there's some up weeks and some down weeks on those, but generically speaking, we're starting to see less of those. So I'm hopeful that, because this is new, DNS is new, those sorts of things to the healthcare industry, I think we'll see those subside. And I know another one that, more on the issuance and onboarding portion of this, where we're asking for organizations to provide information about themselves and authorized representatives to give personal information to validate who they are, to ensure that those individuals are tied to that organization, and there isn't a broken link in the chain, so to speak, of identity. That's new to healthcare. It's not new, as Scott mentioned, to some of the other industries like education and aerospace and the federal government. But for healthcare folks, that's new to us. So it's taken a little bit of explaining to folks to help them understand the value and benefit of a high assurance network from an identity perspective. I'll end there.
And if I,
Terrific.
and this is Scott. If I could just add to what Andy was saying there, I would say that's one of the challenges that we run into quite a lot. Folks who are saying, well, why are you asking us for this information? And we explain the value of identity and why binding to a credential is important, and they understand that. And the challenge is often not that this is so much a new thing to healthcare, in that it hasn't been necessarily called out as perhaps a separate thing within healthcare, because I think in a lot of cases, when folks are showing up to a clinic to provide services, they're asked for certain pieces of information to reliably identify them. And so on the provider side or the patient side of things, they're used to seeing that, and the providers who perhaps start in a hospital or start in a clinic, etc., they'll go through that process when they join the clinic once. And basically our challenge has been to identify where that has been done reliably to the standards that we require, and there are quantifiable risk-assessed standards as to identity vetting, etc. And we apply those to direct trust. And if we can identify that they have occurred in the past, then we can rely upon that and we can move forward very quickly. But where we can't verify that or validate that it occurred to a reliable standard in the past, sometimes we have to ask for that information again. Sometimes folks aren't so happy about that, but when you explain to them the reason for it and the need to reliably identify folks before the credentials are issued and then can be subsequently relied upon, generally they're okay with that.
All right. On that, Scott, you had the last word. Thank you very much, and Andy as well, for really some terrific answers. And thank you all for your questions. We're at the bottom of the hour, and I wanted to thank the panel. I wanted to thank Corey Mertz, Andy Herring, Scott Ray, Ron Moser, Dr. Holly Miller, Dave Anderson for facilitating, and we will, in fact, I want to thank all of you as well for participating. And on the webinar, we've got a couple of additional webinars that are going to be coming up this year on practice management system accreditation, ACO accreditation, and financial services as well, so look for those. With that, thank you all for participating, and have a great rest of the week. And thanks again to the panel for terrific presentations. Take care, everybody.